Yeah, so there's absolutely there's I guess the definition that we used to use a lot and people still do, and I really like it, which is birth trauma is in the eye of the beholder. So really,
Right.
what women say it is, and it should always be that as well.
Right.
And then there are more definitions coming out as well. Julie Leitner from Germany, she did a beautiful review and then definition as well, which looked at what does birth trauma include. For me, I take both of those, and I'm a very visual person, so I see it as an umbrella term. Birth trauma is this umbrella, and then there's all these different factors that sit underneath that umbrella, where the woman may have experienced one of those or many of those.
Right.
Or maybe they've just got something completely different from outside of an umbrella or two. There's always going to be that. So under that umbrella can include things like physical issues, and for vaginal birth, that could be severe perineal trauma.
Right.
So a third or fourth degree tear, or even a secondary tear that maybe has complications, like it doesn't heal well or challenges in that. But what is often not considered under the physical trauma is cesarean scar trauma. And that can cause issues as well. There can be dehiscence, which is when it's quite fresh, but it starts opening. There can be infections. There can be issues with healing. There can be keloid scarring. And then there can be internal adhesions as well. So the healing underneath all those layers, and then that causing problems and ongoing pelvic pain. So that's often not put in the birth trauma umbrella, but I'm advocating that it should be, because it's all part of that physical trauma. Both types of birth can cause some kind of physical trauma. But there's other things there as well, like women feeling like there's a loss of control. That comes up very frequently in qualitative birth trauma research. The lack of support, which I think we saw peaked during COVID.
Right. Nightmare during COVID.
Absolutely. So we really saw that intensify. It can be a lack of informed consent and not being involved in the decision making. And also under that umbrella does fit obstetric violence, which is, is a really, really, I think, pervasive form of birth trauma, because that's to do with the interactions and the treatment by a healthcare provider to that woman.
Well, it's kind of interesting, because it's like, I remember one time being on a webinar with Penny Simkin, and somebody had, typed in the chat about how she works in a hospital and they feel like women get birth trauma because they're not willing to listen to what they say. And so that if they just turn themselves over to this situation, all will be well. And it's kind of like, it's really the exact opposite. It's kind of like they want to be heard, and they want somebody to have a conversation with them and listen. And it's like, it disturbs me when I hear stuff like that. It's kind of like, there was a big review article that came out of the Netherlands, and they kind of found out that the number one issue was the relationship between the woman and her provider, and it's like, did she feel like she was being, shamed or yelled at or, scolded? And they're very sensitive because they're in such a vulnerable position, so sometimes even something that maybe wouldn't in a normal, medical setting wouldn't necessarily bothers them a lot then, when they're kind of feel like they're on their back and they're, up there for all to see. And so it really is kind of, that's an important one. And the other one.
It is. And I would also add to that, one of the ways that's being used over here in Australia, and we had a big birth trauma inquiry a couple of years ago that I was heavily involved in New South Wales. And it was really disappointing to hear from our medical colleagues and their college to actually blame women for the birth trauma by saying it's because they have too high expectations.
Oh yeah, that's big. That is not what the research says,
Yeah. And what's the high expectation is that you get treated with respect.
Yeah.
The high expectation is that you make an informed decision. Like they're not high expectations. These are basic human rights of not to be treated with disrespect and not receive violence, not to be name called and not to be shamed. And it's almost as if, one way of trying to shift the blame of birth trauma and obstetric violence off a professional is by just blaming the woman. And we see this.
Yeah.
throughout,
Oh, which they're high expectations, but it's kind of like, it's interesting because it's like, I'm the editor of a trauma journal. And, it's like when you look at the, the DSM-5 criteria for post-traumatic stress disorder, there's this thing called the event criteria, criterion A, and it's injury or potential injury, physical injury, death or potential death, or, actual or potential sexual violation. And it's like, all of those can happen in a birth, all of them. Yeah. So you meet the definition of post-traumatic stress disorder, and it has nothing to do with their expectations. It's kind of like ridiculous. I mean, people out in the everyday world have an expectation that people aren't going to break into their house and try to kill them. And I mean, are we going to say it's their expectations? I mean, it's kind of nuts. So it's like
expectation to be safe and not to be attacked. I mean, but we've seen this a lot in sexual violence as well, where it's victim blaming for the woman. You shouldn't have been there. You shouldn't have worn that. You shouldn't have expected to go home with a person and not be attacked. There's all that. There's all that blame. You should expect because you're in a relationship just to always have sex and not have to give consent. There is that kind of blame, but I thought that we had kind of moved away from that.
I'd hoped,
and then I did a paper on obstetric violence in Australia, and it was the first one to really focus on that in Australia, and to realise that we really hadn't. We had just shifted it into the maternal space. Then I mean, the reaction that this paper got was amazing, and at times beneficial and at times a challenge. Because it did bring up a lot of these ugly conversations that I then get asked to speak at the conferences all over the place, and I have to spend the first time, advocating for the use of even the term obstetric violence, and then go into all the on what we found. And so, and actually with the second book, because I did a lot of that after the first book, and then I've put a lot of this into the second book too, which has been quite interesting to then put that down on paper and to look, what does that mean then, to look at it from a trauma-informed way, and what could that look like? What could you do differently? And I'm quite interested to see how that lands.
And I mean, it's like I had a paper recently, and all I did was contrast the obstetric versus the midwifery model of care. And it's like, I mean, I had a reviewer absolutely flay us over that. And she's like, obstetricians care too. And so I looked up and I said, this has got to be an OB. And it was. I was able to backtrack. It was an open review where they had the reviewers' names, and I thought, okay, well, I don't think I'm going to be able to convince them about this. It's like, but I mean, it seems like they're, they feel like that this is such a sore spot for them, and it's kind of like, I want to be able to have these conversations because it is really important. But there's this kind of model, where people, and I've been at conferences and, at nursing conferences, which I speak at a lot. And I've had people like wave pieces of paper around saying, oh, she has a birth plan. That's a C-section.
Oh, yeah. Yeah. All right.
Wow. Wow. I'm always amazed. Now the other one that we kind of touched on was fear of life, so fear for her life or the baby's life. And something that we have a lot here when women are trying to, especially having VBAC, is what people in our area call the dead baby card.
Yep.
Which is awful. It's an awful thing, but the people will say, if you do this is what's going to happen.
And I heard a different term.
Baby's going to die.
There's a term. There's more than one term for it. So we know the dead baby card, I think, in the English-speaking countries. And a friend of mine once said, in her home country of India, there was a different term for it, which is called shroud waving. Because it's a shroud that you wrap the baby in, and both are just terrible terms. And I think that we even have it in different. We have different terms for it, but under that umbrella of birth trauma can definitely sit the fear for your own life or fear for your baby's life. But the challenge can be that could be hyperinflated, right? That could be due to coercion, which then crosses into the obstetric violence category.
Absolutely.
Because when you're saying, you must do, if you do this, then your baby will die.
Right.
Then the only reason the clinician is saying that is potentially, I think in most cases, it's for coercion to get the woman to decision that the person agrees with, the decision that the clinician wants them to make. So that can be tricky as well, because you'll hear people say, "Oh, well, I had to do this because of X, Y, and Z, and if I didn't, my baby would die." And you're thinking, "Oh,
Right.
wonder how much that is." Was there some coercion? And then women actually just tell us the coercion. So certainly in the VBAC survey, but also in the birth experience study that I now lead in Australia and 14 other countries, we asked the question about, did you receive hurtful comments, and also did you experience obstetric violence? And we see these comments. They're used like routine. And I mean, I was a clinician, and I don't remember ever using language like that, but it just seems so common that that this coercion is used, and I think it's really inflated in VBAC because of this uterine rupture risk. Yeah. So women have said, if you go for VBAC, your baby will die. Or one woman said in my PhD, she was told, and her partner was in the room, that the person looked at the partner and said, if your wife plans a VBAC, you will end up with a dead baby, a dead wife, and a toddler to raise on your own. So it was completely put onto the male partner to try and then convince and use that influence to change the woman's mind, all based on fear and lies. Mm-hmm. Because when we actually look at the risk, and I mentioned uterine rupture earlier, when we look at the risk, and I look at the largest study that's been done to date, which is the INOS study, and they looked across Europe, 10 years of data over 10 countries, and they found a uterine rupture rate of 0.22%. Yeah. And then from those women, and from the women that did have a uterine rupture, that 0.22% was something like 800 and something out of 2.5 million. Those women, 2 of those women died, and 90% of babies survived. So even to say, if you have a VBAC, you will have a uterine rupture, well, we know that's not going to happen because there's a very small amount will do that. And then to say, and you and your wife and your baby will die, that is like, the odds of that are very, very small, but they're just seen as causality. And so this just puts fear into people's minds, and that just keeps feeding the 100-year-old plus thought that once a cesarean, always a cesarean. And that just all feeds into it, which is why I've written 2 books on this, right? To try and convince people, not to convince, but try to educate people on what the risks are and what the other risks are to repeat cesarean, and then how to make the best decision for them, and how to reach that, and then how to find peace along the way.
Well, they don't seem to be nearly as concerned about possible complications and death with inductions, which I think would probably have a higher rate of things like uterine rupture. Yeah. But they don't seem to be as concerned about that. But those they get recommended all the time. So it's just kind of amazing. I was going to actually talk a little bit about some of these things that you saw were specific barriers, or at least clinician-used barriers for VBAC. And you had a whole bunch of them. And so I was thinking maybe we could just talk about kind of each one briefly. The first was the Women's Body Mass Index. And you used very respectful language in there, which I appreciate. So good job.
Look, I've got a whole bit in there about a whole chapter in there about the VBAC calculator. And this is one of those things that comes into that VBAC calculator. And it really surprised me when I did a bit of a deep dive into all the different scores in the VBAC calculator. Probably the biggest deep dive I've ever done into it, which was really quite fun to do. And there's a lot of body shaming that goes on with it. And we know that women with larger bodies have a harder time in their healthcare, in maternity services, but also in healthcare, and women generally throughout healthcare. And it basically, in this tool, would give higher scores, which was a positive. A higher score was more chance of a VBAC, the thinner you were. And it really went to quite a ridiculous weight, which we then also know would have such a severe impact on the baby and the mother. But hey, she'd have a high chance of VBAC, so that's fine. And then on the other end, if you had a higher BMI, then you had less chance and you were scored lower. So even though there is some potential evidence that looks at it, it never really looks at why and the fat shaming that happens,
Right.
and how that then can impact the woman and what message that is telling the woman. And we see this over and over again. Sarah Wickham has written a book on plus size pregnancy. Some other people have as well, and we can just see how even just the viewpoint of using a calculator that is set against women who are larger, means that you are feeding into that as well, feeding into that fat shaming. And in our birth experience study, we use the same survey in all these different countries, but the research groups in the different countries can add interest questions if they want to.
Right.
And throughout Sweden and Norway, and I think Denmark may have done as well, they added, and they will do in Brazil, they can add it in their survey, they added questions around fat shaming. So actually asking women, not just those planning a VBAC, but women who've experienced maternity care in the previous 5 years in that country, what their experiences were if they were larger. And it's they're looking at the data now for the Swedish study, and looking at the qualitative comments, because they had an opportunity for qualitative comments. And it's devastating to hear what women were told, and on such a large amount too, because the Swedish study had over 17,000 responses.
Oh, wow.
So we can really see the impact of this and what this does to women. So yeah, it is a barrier. It's a barrier for women, but not that it should be, because you're the size that you are, and that shouldn't be shamed. But it's a bias for the clinician, because if they potentially are going to then not support you in the journey to VBAC if you're larger, because of all the biases they've got.
Yeah, even if you're larger but happen to be very good in things like blood pressure and cholesterol and all the other markers of poor health. Yeah, they take that one marker. I know they do the same thing in lactation too. It drives me absolutely up the wall. But yeah, that it's kind of interesting, especially with BMI, because you would think that this would be a group you'd want to push toward vaginal birth.
Well, absolutely, because the
surgery is harder.
Yeah, absolutely, and they definitely then go into the potential for the physical trauma to do with cesareans.
Right.
So, we know that there can be more issues with wound healing, more chances of it dehiscing and the sutures being looser, and also for infection.
Yeah.
So what annoys me is that this is actually about the baby and not the woman.
Mm.
This is about, well, we want to get the baby out of this woman who's larger. And, if she has complications afterwards, well, whatever. That's her fault, right? Let's blame the women again.
Right.
But we've got the baby out.
Right.
And that's that whole attitude of the baby means more than the woman. And that we've got to be careful when that happens, because they're not talking about uterine rupture risk being an issue really for the woman, because most of it's about the dead baby card, isn't it? It's about getting this live baby out. And I mean, all women do want that, right? Women do want to have a live baby, but it gets to the point where that is more important than the woman's own decisions and how the woman then heals afterwards as well.
Well, the interesting thing about that too is it's kind of like this whole idea of the best outcome, or a positive outcome is live baby, live mother, but they don't care how they get there, and I think that's so from a lot of times OB's standpoint, it's kind of like, well, live baby, live mother, what are you complaining about? And so again, it kind of comes back to this whole psychological stuff. They're kind of like, what? And it feels like that makes a huge difference in terms of so many other things.
And a live mother, it may well have a pulse. However, she can be traumatized.
Yeah.
She can have problems healing. There can be so much else going on. And who's then looking after that baby? Like, we actually we want live babies, absolutely, but we want thriving mothers.
Right.
We want well, empowered, strong, healthy mothers, because that's when they're doing the most important job in the world, which is then being a mum to that baby.
Well, and it's
the
like
hardest job in the world, as I know. It is the hardest job in the world to then be there and be present and care for your baby in the challenging world that we have.
Well, we just finished watching this Leanne Moriarty show, but it took place in Australia. But this woman has a, emergency C-section. She started bleeding. And so they whisk her in for an emergency C-section. And the whole rest of the time, she is so disconnected from her baby. And she just feels like everybody can take care of this baby better. And she was actually planning to kill herself and leave the baby with somebody else, and it was just like, it was kind of making me scream. Nobody was seeing this.
Yeah.
And, she's in the NICU and they're kind of like, okay, here you got a pump every hour. And it's like, there's no skin to skin. There's no kangaroo care. And I'm kind of like, no wonder she feels so disconnected. And nobody was seeing it. And it was just, it was driving me as a provider. The provider would be like absolutely nuts. Okay, size of the baby obviously is a big one. That's a big reason why a lot of times women are told they need a cesarean. And they can be quite off in terms of birth size.
Oh, absolutely. It can be very, very inaccurate. And even if they're accurate, to be honest, it still doesn't mean that the woman was not able to push that baby out.
Yeah.
If there are the true cases where the baby is big and doesn't come down quite right. And there is the baby's getting stuck. We do know that can occur. And thank goodness we have the opportunity to go for cesarean at that point. So I'm not saying it never happens. There can be the case where the baby is a decent size, gets the head out and then gets the shoulders stuck. But being a big baby is not the only risk factor for that.
Right.
That can certainly happen in any size baby, because that is really about the mechanisms of how the babies come down and the pelvis, and we're seeing high rates of that, especially with supine birth, so lying flat on your back.
Exactly. I was going to say that probably has a lot to do with that.
Birth position can have an impact for that. And the big baby worry is that they're going to get their shoulders stuck. Even though we've also got good mechanisms to be able to help with that. So it's a preventative issue. But again, it's then used, especially when you've had a previous cesarean, as a weapon to avoid you from going for a VBAC in the first place.
Absolutely.
Even though you can become educated and clinicians can know that, you really you don't know until you know that, you don't know until you're in labor, and there's lots of things you can do to try and help that. But instead they're just like, nope, let's go. And then basing that on an ultrasound that could be grossly inaccurate.
Or sometimes just like hand measurements. I remember saying to my midwife when I was pregnant with my second baby, I said, this baby seems big. And they're kind of like, no, this is going to be a 7-pound baby and everything. He was almost 11 pounds. And the thing is, I'm actually glad I didn't know that, because I think it would have psyched me out. But I had a midwife the second time and I was upright. And I mean, once the urge came to push, that was it. And people kept saying, he's so big, he's so big. He didn't look big to me. I had a 2-year-old at home, so
that's true. They still look like tiny babies, don't they? I mean, look, women can birth big babies. It doesn't mean that there's never going to be any complications.
Right.
Because, that can happen. But again, a lot of that is blamed on the woman rather than on the fact that
she's on her back and
the support wasn't there, and she wasn't encouraged to do different positions and stuff. So it is used a lot, and I think a lot of that time it's unfair, or even the history of a previous large baby, can then influence that as well.
Yeah. Okay. Now, something I think you're familiar with which is the interpregnancy interval.
I'm very
short interval, obviously, I've heard people say, well, you can't have a vaginal delivery after that. You haven't healed enough. And, if there's a short interval.
That's the reason, they're hoping that, the uterine scar has healed enough to be able to then hold another pregnancy and go through labor. And the thought is that the shorter that is, the less likely it's healed.
Right.
Not that we do any internals, or would we want to check healing. We don't. It's all just gone on guesswork a lot of the time. When I had my first and then was pregnant very quickly, a paper had just come out back in 2007. That shows how long ago it was, and that one really was good because it broke it down in areas, so in different sections and time frames. And the one that I fitted in, which was less than 6 months from conception, from birth of the first one to conception of the second one, and that's interpregnancy. Interbirth is from birth to birth, and we shouldn't really use that one. It's about interpregnancy. And that was less than 6 months, and I fitted that because mine was 4 months. And so my uterine rupture rate went up to the whopping 2.7%. And when I've been reading papers all weekend, which were like less than 1%, less than 1%, and then to jump to 2.7 sounds huge.
Right.
And people will just be told you can't. Like, that's what I was told, you cannot. However, I put it to my husband, who's my walking calculator, to be honest. He's amazing with maths, very math analytical brain. And I came out of reading all these papers and I was just devastated. And I said, I'm going to have a repeat cesarean. No one's going to allow me. I can't believe I even used that term. And he said, why? What's the issue? And I explained it was 2.7%. And he just flipped that and he went, so over 97% of no risk at all, like nothing happened to you.
Right.
He said it's more dangerous for you to get in the car and drive to the hospital. And we live on a highway, and there's only one highway in our area, right? So when it gets blocked, there's a standstill and no one can go anywhere. So it is pretty dangerous to get in the car and go to the hospital. So I was like, yeah, you're right. I think I should just plan a VBAC. And did. But it does get used on women all the time. I'm actually supervising a PhD student at the moment who's looking at interpregnancy interval, and she's actually looking at population data in Australia.
Interesting.
And also we did a qualitative study asking women what they knew about the interpregnancy interval, and we're doing a co-design of a resource as well, all within one PhD, which is huge, but she's doing a grand job. And what we have found is that women aren't really aware of it, and that they're told lots of different information and lots of different definitions as well. So certainly more education needs to be put into that spot. But the message I try and put across with that is it may increase it. You've got to feel comfortable with that.
Right.
However, nothing equals 100%.
Right.
So, you then got to go, what's really, for women, they've got to know what's at the core. And as a clinician, you've got to trust and respect the woman's decision and not try and use coercion because you're fearful of shortened pregnancy interval.
Well, what about multiple cesareans? That's, I know, is one that gets used frequently. If you've had especially more than one.
Yeah, absolutely. Now, the data is very supportive for two, for 1 or 2 cesareans. And again, it's the same kind of issue as the shortened pregnancy interval, is that potentially the more cesareans you've had, the higher chance you've got of a uterine rupture.
Right.
Again, it doesn't equal 100%. So we don't have a crystal ball. Like, we can't just look at it and go, oh, this will definitely happen to you. It can make that scar area thinner and thinner and thinner, almost like a transparent window. But some women still can go on and have vaginal births after cesarean without an issue. So again, it's got to come down to trusting why the woman wants to make that decision in the first place, and then supporting her. I've done a series of workshops around the place, both did one in the US and in the UK as well. And I love these workshops because it's interprofessional, so I'd get midwives and doctors and doulas all in one place. And there was a doctor once, an obstetrician, who was a beautiful man. And we were talking about all these extra things like multiple cesareans and shortened pregnancy, all the things that we might get upset about. And he just turned around and said, well, at the end of the day, I'm not treating them any differently. Like, if they're in the hospital, because he was a private obstetrician, if they're in the hospital that I'm caring for them in a private hospital, then I'm going to be obviously using continuous monitoring, because that's what he suggests and what the guidelines suggest. And they've got access to theatres. And so, like you said, at the end of the day, there may be an increased risk, but I'm monitoring it in the same way, and I'm still transferring to theatres if needed. So it's almost as if that, not that it doesn't matter, because all the other stuff matters, like support, but there's not going to be any difference. Like, you can't just add another wrap of bubble wrap and then another wrap of bubble wrap on top of the woman, right? Like, you're still going to be doing the same monitoring and the same observation and the same criteria for moving to theatres.
Yeah, I met an obstetrician when I was down in Fort Worth at a birth conference, and he would take women who had had up to 5 cesareans. I mean, it was unbelievable. I thought, wow, okay. And there was he was there with a patient of his who'd had 5, and she was there for her, had her 6th birth as a VBAC. And I think, I think a lot of people wouldn't have chanced that, but this guy, he did it regularly and he was willing to do it. So it's kind of like I
The
thought,
hardest thing actually is to get the support.
right.
So if we look at our Australian data for our yearly maternal data, then we can see that the rate if we had this whole pool and they've all had a previous cesarean, and then we're looking at what happens in their next birth, then by far the majority will have a repeat cesarean. It doesn't say whether they planned it or it was unplanned, so we don't know. And so we've got 80+% having a repeat cesarean, and it's 14% of women will have a VBAC after one cesarean.
Right.
And then there's about 2% in there that have forceps or vacuum. But if we then were to up it, and the only one they let you look at actually is VBAC after 2, there's no option to look at any of the others, that 14% goes down to something like 2%.
Yeah.
So it's not that, when I interpret that, it's not that women don't want it, it's that the support to actually get it is really hard.
I think that
because we don't see it very often.
No.
Like it's seen as, having a VBAC is rare enough if only 14% of that population are doing it. And then if you're looking after the whole population, imagine how much smaller that is. Then to have a VBAC after multiple, it's just the support gets harder. So I think choosing the team, choosing the healthcare provider becomes even more important with that.
I think it's really critical because, I mean, there's going to be whole areas where you can't do that. And like in the U.S., the guidelines changed that said you had to have an anesthesiologist like on the property. So if you're at a small regional hospital, that's just not an option. And
we've got that here where I live. We've got a small hospital, and there's no VBACs there because they don't come up into the risk category enough because of not having 24-hour theatre staff. So, but however, though, like if a woman literally comes in with a cord prolapse, we will get them to theatre really quickly and do everything we need to do.
Right.
And they'll come in and do that. So the risk regional rupture is kind of on the par of the rare cord prolapse. And so, it then kind of beggars question on, really, like if we can open the doors to any woman in an emergency, manage it, get the staff in, and then go in, then what is the issue with VBAC?
Right. Like, I know here it's become an issue with insurance. That's been a big issue, that they can't get malpractice insurance, and the midwifery insurance is not nearly as high as it is for OBs. But I mean, they can't practice without it. And so it's kind of like that seems to be one of the big drivers. Now, breech birth, of course, is another one that they always use, even for first births. If you have a breech presentation, it's kind of like, well, you're going to have a C-section. And then Ida May showed us you can do it. Well, I was going to say that Ida May showed you can do it.
Yeah. We can. And I think over here in Australia, things are slowly moving. Like we do have breech clinics now. I mean, unfortunately, one of our obstetric gurus in breech has literally just retired last week. And he was amazing, Dr. Andrew Bissett's, but he has educated a generation of OBs. So let's just hope that they take on on that kind of challenge. But we've also got, I think which came from the US, the Breech Without Borders program. So we've got more and more training happening, and so but still I would say routinely it is going to be a repeat cesarean. However, that doesn't mean that, so the ACOG guidelines that you have and is then kind of really replicated around the world, they do say that you can go for an ECV, and so an external cephalic version to try and move that baby from breech to head down. And that's okay. And actually, I had I had a participant in my PhD who was a very well-educated, well-resourced woman and a professional herself. And she was in midwifery group practice, so she had a continuity of care with a midwife. She had a doula, all the stuff. And then her baby was breech. And her hospital that she was going to would not do an ECV on her. Okay. But because she's well-resourced and well-educated, she found out that a hospital just half an hour away would do an ECV on her. And they wouldn't give her a referral, so she self-referred, and she got accepted. They did an ECV on her. She was successful, and so the baby went head down and stayed head down.
Yeah.
And then she went back to the hospital and said, "Well, I'm head down now, so we just keep going." And they were so impressed that this other hospital did it, even though they're literally down the road from each other. They're in different local health districts, right? So there's like never the two will talk, but they're literally just down the road. They kind of marched her through the clinic and went, "Oh my God, look at this woman!" Like she became this, piece, and apparently, hopefully, changed the policy on that. But not that I ever got a chance to go and check that. But this is what she reported to me. She said, "Oh, then they were going to change the policy based on what I had done," and so that kind of thing is okay. And to be honest, if your baby is then breached and you're a VBAC and you've got the most important part with that is that you've got clinicians that feel confident and are skilled to do that. You don't want to be having a breech birth for somebody who's not confident or skilled.
Right.
So if you're going to go into that, you've got to check, are you comfortable supporting me? Do you know what to do? Have you been trained in this?
Yeah.
And we've got some private midwives, which are like your community-based midwives, who are very skilled in this, because sometimes unplanned breach happens at home. And certainly as a home birth midwife myself, I saw a few. Yeah. And you need to know what to do in that situation. Whereas in the hospital, you could just buzz and somebody else might come in. Right. So yeah, it shouldn't be an issue. You should be able to, but it's all about, first of all, if you want to have an ECV, making sure that they're comfortable. If not, change the policy. Right. And secondly, if you're going for a breech feedback, just make sure that the people who are going to support you know how to do a breech.
Okay, so the next thing you mentioned was special scars. That's a lot of times the reason why women are told they can't have a VBAC. They have a special scar.
So basically, what a special scar is, it sounds like, you've got one with glitter on it. But what a special scar is before I mentioned that there's going to be a lower segment scar, but occasionally that's not enough. Or in a premature pregnancy, for example, that lower bit hasn't quite come up enough to be able to cut there. So they might have to do a vertical, so an up and down. That's the more traditional style. Right. Or more commonly, when there's difficulties getting the baby out in a cesarean, they do the lower segment and then do an extra bit, like a bit around the curve, or in the middle they might come up and it looks like an upside down T. Mm-hmm. So there's all these different things. There's a list of all different special scars and it's just good to put them into special scar. There's also the previous uterine rupture group. So women that have had a previous uterine rupture and then have another pregnancy, and that can come under special scars as well. Now, there's really not much evidence on this because it's quite rare to begin with. And then all the policies basically say if you've had one of those, you are a repeat cesarean at it used to be 37, maybe they've moved it to 38, I'm not sure, but, literally just before 40 weeks, so that you don't even go into a labour and risk it. Right. But there's very little that's based on. That is really based on expert opinion and maybe just a few papers, because it's so rare, it's hard to get the big studies to look at it. So what's missing, though, is women's experiences of special scars, right? Especially after uterine rupture. So I do have a Master's of Research student at the moment, and she's just finished interviewing. I think I've got the last interview today. And she is doing a small qualitative project on women who've had a uterine rupture, and then what their experiences were, and potentially what they would do next time as well if they were to go on and have a pregnancy. Because we just don't have that qualitative part. And I think research is never complete unless you've got equal of quantitative and qualitative, because the quant can tell us that you should do something because the numbers say so, but if that doesn't fit with actually what women want to do, then it's pointless. So I think you always need to have both, and so we're exploring that now. And yeah, certainly in my national survey, I had a handful of women who said they had previous special scars and went and planned a VBAC, and about half of them had a VBAC and half of them didn't. So it's not that women want to just follow the policy of don't do this. They actually want to explore it. Right.
Well, that seems like that's a particular fear factor for the clinicians. I think they hear that and they immediately think, really scared. Yeah. So it seems like that's an issue that just everybody.
But like this doctor who said to me before, you would be treating them the same in the hospital. You'd be using the same monitoring and the same observations and moving to theatre for the same reasons. So if you're in that space, what would really be different?
Right. I think probably one of the biggest contentions again with that is should they even have a trial of labor? and it's kind of like, yeah, but there's a lot of benefits of that.
Yeah. And at the end of the day, what does the woman want to do?
Right.
Like, what is it that's really in her heart, in what she wants? And there's different ways to bring that out as well in women. Like, just kind of asking doesn't always go there, but there needs to be a process that the woman can really explore what is it that she wants, and be able to change her mind as well.
Right. Well, obviously, I think birthplace is one of the big issues about whether this is, people would consider this safe to go ahead. What can you say about that? Birth center versus hospital versus home.
Yeah, well, sometimes being in a hospital doesn't feel safe for women, especially when they've had previous birth trauma. So if we're trying to think about it okay, first of all, the woman has chosen to have a vaginal birth after cesarean. We know that to be able to have a good labor, or a labor that has the vaginal birth, we need that oxytocin-rich environment, because that is the hormone that we need for labor and love. And therefore, then the woman has to feel safe to be able to get into that space and to have that hormone flying around her body. And if going into the hospital causes her to feel the opposite and causes her to feel adrenaline, then that's actually not going to help her in labor anyway. So for some women, and for many women actually, and we don't really have the numbers because we don't record it very well, many women will choose to have a more safe environment, such as their home. But not all women have a safe home, or feel safe in hospital. And so that's where a birth centre might come into place as well. They might feel more comfortable there.
Yeah.
So often I did one of the first ever home birth after cesarean studies, a qualitative study, which was my first ever project, my first ever research project, where I interviewed women who'd had a VBAC at home. And I wanted to know why and learn more about it. And their journey was really interesting, because many of them hadn't chosen this from the beginning. They had gone back to the hospitals and they got pregnant, and they knew that they wanted a VBAC. And they also knew what didn't work for them last time. Being induced didn't work for them. Being on a CTG didn't work for them. Being strapped to the bed with an epidural did not work for them. And they've educated themselves on, I want to be upright, I want to have dynamic birth positions, I want to be active in labour, I don't want to have a CTG, I want intimate monitoring. They will say all these things, I don't want to have a cannula, all the things that didn't work for them last time. And then they would try and negotiate that with the clinicians in the hospital, and they would be told, no. No, 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 no. And then the woman goes home and they're like, okay, well, I can't do it that way. And I think this is a pivotal moment. Do I just fight it? Do I go for a repeat cesarean?
Right.
What else is out there? And often they would pick up the phone to a private midwife, and then they would hear yes, 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 yes. And then they develop this really strong relationship with the continuity of care midwife. They then feel all the things that they wanted to do in the hospital, they could now do at home. They could use the water. They were told they can't use the water in the hospital. They can now have a water birth. They don't have to be continuously monitored. They've got people supporting them, and then they fall in love with having a VBAC and then have a VBAC at home. And now I try and convince them to go back to the hospital. So it's actually a reflection. Sometimes it's a reflection on how rigid the hospital is. Like, if you're not going to negotiate, then don't expect them just to follow your rules. And then actually what happens is that women want to negotiate on their care, clinicians say no, and then it just gets nastier, 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 and nastier.
Yeah.
Just with the comments, if you do this, I'm going to report you to Child and Family Services.
Right.
I'm going to call the police on you. Like, it gets really ridiculous when all the woman wants to do is be upright and mobile, not have a CTT and get in the water. Like, we're treating them like terrorists, and they just wanted to have a natural birth. So it's a complicated area, and people want to just come back to, is it better for women and babies in the low bar of live baby, live woman, to have on place of birth, which is one way of looking at it. And actually, if we look at it that way, it's kind of okay, as long as there's good transfer options. And the woman will get listened to as soon as they arrive if there's an issue, and there's no delay in the care. Then it's kind of okay on that part. But it's actually deeper than that. We actually need to explore, why has the woman made that decision in the first place? Was it her first decision? Was it a reflection because we're being really awful to her in the hospital? Did she have a really traumatic birth? And there are things does she actually want to birth in the hospital? And there are things that we can do to support her with a trauma-informed framework. And actually, if she chooses to birth at home, support her and love her for that. And just ask her, well, who's there with you? What support do you have? Oh, you have that midwife. Oh, I've heard she's fantastic. That's great. Like actually encouraging it. And then always saying, our doors are always open to you. If you're in labour and you feel that you want to transfer from home to hospital for whatever reason, we've got open arms for you. We will accept you and we won't judge you. If only that was true in every single scenario.
Oh, boy, that would make a difference. Yeah, that would make a huge difference. Okay, so one of the things that you mentioned was about the importance of mothers having control during their births. What does that mean, and what kind of control should they have? What do you think are things that are reasonable for her to have control over?
Yeah, it can sound quite strange to midwives and maternity clinicians when we talk about control during, labour and birth, because it can be, by nature, it's unpredictable. You can never say this is exactly how it's going to be like.
Right.
If you plan a cesarean, you never know if there'll be complications. So it does sometimes put people on edge when I talk about that. But let's take it back to the birth trauma. Remember how I said that many, many women say that they feel that they lost control,
yes,
and that contributed to them feeling like they had a traumatic experience. So the flip side is being in control. And so what came from that, and this all came from my PhD data, not just from my opinion, was that being in control meant that the woman felt that she was in control of her choices, what type of birth, where to birth, her dreams, her wishes, like really what she wanted to do that was core to her, and then her outcome. So even if things had been gone in a different journey or a different path, she was still part of that. And so that's really being, from the clinician's point of view, that's us respecting the woman's choices. If she says she wants to have a VBAC, we then don't try and coerce her. We go, okay, right, you want to have a VBAC. She then says, I want to, these are the choices I want to make for my labour. Then we facilitate that as much as physically possible. Like she wants to hang upside down, or we might not have the right equipment. We just be honest about that. She wants a dolphin in her birthing pool. We might have to say we don't have any dolphins. So like within reason, but we don't lie and say, oh, there's no birthing pools here, and we know that there are, or we close the doors to the rooms that have them just because we don't want to. So it's her having and feeling like she's had control and made all the decisions, and they've been respected all the way through to if, say, she planned a vaginal birth and she had a repeat cesarean, that things were done during that repeat cesarean that she had chosen as well. That might be delayed cord clamping, that might be, skin to skin and no separation. It might be a certain music, like it could be all sorts of things. Who's there with her? Within reason, obviously you can't have an old audience there, but who's there with her? So those choices are still made by her. So at the end of it, and obviously there's the 4 factors, so this is just one of those factors, if she felt that she was in control of that, then she's less likely to feel that was a traumatic experience.
Well, that kind of leads me to kind of my last question, which is, we talk about the situation where a woman plans for a VBAC and then ends up with another cesarean, but feels good about it. And I think, again, having control over that decision, I think, is one of the factors. It's not emergent. People sit down and say, this isn't progressing for this and this reason. What do you think? I think we may need to do this, and it's a decision that she gets to participate in, not just like, we're going to do this and it doesn't matter what you think.
I certainly went into my PhD after my master's, which was all about VBAC at home, with the thought that it was all about the vagina. Like, it was all about getting this baby out of the vagina. And obviously that was my viewpoint going in, because that's what I'd experienced.
Right.
And it shifted. And I'm glad it did, because it's now more to do with what women have actually said to me.
Right.
So, and one of the pivotal points that it shifted was one part of the PhD was following women all through their pregnancy and then interviewing them afterwards. And I had a little app that I developed where they recorded their experiences during pregnancy and after every appointment, and then I interviewed them. And I would often go to these interviews not knowing what the birth outcome was. It was like the best soap opera ever, I've learned all their stories. I've got to know them really well because they'd done all these recordings. And then it was like the ultimate cliffhanger. I didn't know what the outcome was. And I did 2 interviews in one day, quite close geographically to each other. And one was in the morning, one was in the afternoon. And on paper, so if we were to read their notes, it would look identical.
Right.
Well, they both got to fully dilated and both had a repeat cesarean. So you'd look at that and go, oh, well, that's the same. However, their interviews were chalk and cheese. They were two ends of a spectrum. And one was devastated, blamed herself. And the other one felt empowered and felt that, well, I did all of it except that tiny last little bit. And that really set me on a big reflection. I remember like doing one, writing it, doing the other, writing a reflection, then sitting down after both and going, oh my God. And then I did a narrative analysis. So it wasn't just those two. I had like 13 women and I had all their stories complete. And I sat and I compared every single story to each other, which is what you do in a narrative analysis. You don't pull them apart like you do in thematic analysis. You keep them as whole. And it came to me that actually, you can have a cesarean and feel amazing. You can have a cesarean and feel bad. You can have a VBAC and feel amazing. You can have a VBAC and feel bad. So it's actually not going to be about the vagina. What else is going on here? And that's when those 4 factors came through of control, confidence, relationship, and active labor, which I'll go into detail in both those books. And if they felt that they had a positive experience across those 4 factors, they were more likely to feel, either joyous and amazing or accepting what happened compared to being low on those 4 factors and then feeling really bad. And this has then had a really interesting impact for many women out there in the community who've read the book and have heard me talk when they have had a cesarean and actually felt okay about it.
Yeah.
And it's really interesting that they then can look at these 4 factors and go, well, I did feel like I was in control and I had confidence in my abilities and my healthcare providers' abilities. I had a good relationship. Maybe they had continuity of care. And I was as active as I could be in labor. There was nothing more I could do at that point. And I had a repeat cesarean and I feel all right with that. But then it's an interesting space to be because people would often be left to feel that they shouldn't feel okay about it.
Right.
That, you didn't get what you wanted, so therefore you should be disappointed. And so through this framework, this has actually given many women who've had a cesarean the opportunity to go, oh, okay, this is why I felt okay. And then that doesn't mean that next time they don't want to have a VBAC. Many of them do go on and say, well, I feel okay with this, but I still have that yearning desire to have a VBAC. So I'm going to do that too. But they've now got this framework to go, this is why I feel okay. And although in my survey, I didn't have anyone who had a VBAC and not feel happy, I have seen this out in the community. So especially on like social media, on a few of those groups. And I was just coming to the end of my PhD when I saw a post where a woman spoke about her vaginal birth and how devastated she was with it, her vaginal birth after cesarean. And that was because she experienced obstetric violence.
Yeah.
So, she had lost all that control. That control factor had just gone to 0 in that moment. And then it impacted the rest of the experience. So this is why it is more important for us to think about that journey and think about those 4 factors than it is to think about what's the final outcome. I've often then had hospitals say to me, but we need to increase our VBAC rates, Hazel. How are we going to do that? And I say, well, if you focus on those 4, you actually will.
Yeah.
Because one of them is active labor, right? So the more you increase that, the more chance they're going to have of having a vaginal birth. One of them is relationship, which is really about continuity of care and really favoring, because of the data, not because of personal preference a little bit, but mainly data, preferencing midwifery continuity of care, which also then will increase your chance of vaginal birth.
Right.
Having confidence in yourself also comes down to learning what you need to do about how to be active in labor and how to care for your body, which will end up with a higher rate of vaginal birth. And then having that control and making those decisions overplays all of that. So if they focus on those areas, they actually would increase their VBAC rates without having to focus on their VBAC rates.
It's interesting because it's like when I was working on my first book, which was way back in 1992, but I was looking at this issue with birth trauma. I really kind of wanted to talk about it because I was hearing it from so many women, and my own personal experience, but it's like I really wanted to kind of see, okay, what, seems to be kind of the issue. And it really did come down to it's the subjective experience of it, because the way it was kind of framed at that time in the literature was C-section's bad, vaginal birth good. But I was meeting people at every, end of that spectrum. That there were women who had cesareans that felt okay about them, women who had vaginal births that described them as rapes. So it's kind of like it really kind of comes down to what are those other factors. So that's exactly control, and was one of the big ones in decision making, and all the knowledge and feeling confident and feeling she had support and people were being nice to her. And I mean, these are all things that made a difference. So yeah, it's like, bam, I'm kind of absolutely agreeing with what you're saying. So I think we're going to have to kind of wrap stuff up here, because I think we've gone way past time, but it's been a lot of fun. But I encourage all of you who are listening today to get copies of Hazel's book if you want to know more about this topic. If you're in the field, you're a professional, if you work with new moms at any stage, please pick up these books. They're both available on Amazon. Hazel comes and speaks quite a bit. Hazel, do you have a website that people can go to?
I do. People can just go to hazelkeedle.com and you can see all my links to the books, as well as workshops, all my papers linked on there. So, and a contact form too. So you can find me at hazelkeedle.com.
So thank you so much for being here. This is such important work. And I think this is really obviously making a difference for lots and lots of people around the world, because we just, the sales have been brisk on this. So it really shows that there's a need. So it's like, I'm so pleased that you did this, and you did this in such an evidence-based and kind of balanced way, and shared so many women's experiences, because I think that's really kind of, you're not going to learn what's going on unless you hear about their experiences, because it's that subjective interpretation that really is going to determine whether this is a good experience or a bad experience. It's less all the obstetric stuff. Women can go through a lot of really frightening stuff, but if they've got good support and people explaining to them and everything, they can come out okay. And, in contrast, they can have a birth that on paper looks just fine, and they're devastated by it. So I really think you've really gotten at kind of what are some of those nuances in terms of studying this. So I think it's really important. So I want to say just thank you so, so much. So thank you for tuning in to this podcast. If you like, be sure and leave some comments, or if you want to get in touch with Hazel, so hazelkeedle.com. And until next time.